Hello and welcome everyone. Today we'll be discussing about the role of non-insulin diabetic medications in ICU, the risk associated with them, the pharmacokinetics and how to manage them. Now, diabetes is pretty common in the ICU because it has increased in the community because of the sedentary lifestyle and the obesity in most places. The practice is evolving. We have been continuing to use IV, but people are trying to continue with the tablets. Let's see what the literature says and what our practice should be. We must understand there is a very complex pathophysiology by which these anti-diabetic agents, which are non-insulin, they work. So why ICU is a challenge? It is a challenge because there is an altered drug handling. In critical illness, there is organ failure. There is significantly altering the pharmacokinetics and pharmacodynamics of these drugs. So what are the alterations? The most important is the renal impairment, followed by GI dysfunction and also skin hypoperfusion. So what is the guiding principle? The guiding principle which has been till now is that we stop everything and start insulin. But we can individualize it, taking into risk the potential toxicity and the lack of effects. So the two major high risk medications that we have, which we will deal with first, are the SGLT2 inhibitors and the metformin. SGLT2, it acts on the kidney causing the glucose excretion and it is insulin independent. Now the dangers are that it can cause euglycemic decay, which means that you get a very high level of ketones when your sugar levels are nearly normal. The risk factors is again critical illness. So in ICU, it is always better to discontinue this medication. So regarding SGLT2, the most important thing, do not continue it. It has to be stopped. And they must not be continued and you should wait for starting this patient, at least even in hospital. Current international guidelines do not recommend to continue it. Metformin, it is the most common drug that is used. It reduces the hepatic glucose production, increases the insulin sensitivity and has a low risk of hypoglycemia. But it does cause what is called as the lactic acidosis. The primary risk factor again is critical illness, where you have shock, where you have renal impairment. All this can cause lactic acidosis. So the clinical course of suspected metformin associated lactic acidosis relates with the lactate concentration, which has very significant mortality as well as renal replacement therapy requirement. So in ICU, it is better to discontinue if your patient has shock or chances of renal failure. Regarding the insulin secretagogues, they act by increasing insulin secretion and they will do it glucose independent. So there is a very high risk of hypoglycemia here. So it will be very risky to continue these medications, especially if the patient has any renal or kidney impairment. Again in ICU, they must be stopped. Regarding the incretin agonists, they act by delaying the gastric emptying and they have a pretty long half-life. So that is a significant risk for us. And in ICU, because they delay the gastric emptying, it is better to stop if the patient has multi-organ failure or shock or something like that. It will be prudent to withhold it. If you want to continue, you have to check the risk and benefit. Regarding the DPP4 inhibitors, they are removed by the kidney and they do carry a small risk of pancreatitis and they also increase the risk of heart failure. So it will be prudent to stop them in the ICU. Other non-insulin drugs are the thiazolidinediones and the acarbose. They also should be discontinued for all practical purposes because they cause fluid overload and GI dysfunctions. So this table basically summarizes what needs to be done. SGLT2 and metformin should be discontinued. Sulfonylureas should be stopped. GLP-1 and DDP4 should be withheld, and it's better to avoid the other agents because of the fluid retention risk. So always follow the 6-day principle, which means that you start these medications only after the patient is taking everything well for at least 24 to 48 hours. So to prevent the harms of DKA, AKI, lactic acidosis and possible hypoglycemia, it is better to avoid this medication. So despite all the advances, the core ICU strategy still remains insulin therapy. So always go back to insulin therapy because it is predictable, titrable, and in the complex ICU setting, this is the best drug that we can use. and with a very good pharmacokinetic and dynamic, which we understand at least in critically ill patients. So the key takeaway is always individualize your decision. If the patient is only for observation or post-op management, you can probably try to use the other agents. There are no such trial data to support the use of these agents. And always follow the 6-day rule and prevent the complications if at all you are continuing. So regarding safe NIDM management in critically ill, understand the pharmacology, the risks associated with those agents, and always know that insulin is one whose pharmacokinetic and pharmacodynamic we know very well. So focus always on insulin therapy during critical illness and follow the 6-day rule. Thank you for your patience.